So thank you for the opportunity to present at the SLAUS meeting, and I feel I'm in the lion's den here, trying to speak about bladder preservation to urologists. And I will basically be going through some myths and trying to debunk some of the myths related to bladder preservation in muscle invasive bladder cancer. So basically, we know that the moment it is one of those tumor types where there is a significant shift in survival when the stage goes from T1 to T2. I don't think we see this shift in any other tumor site. So superficial bladder cancer is eminently curable, cure rates more than 90-95%. But moment there is muscle invasion, 5-year survival will drop to nearly 50%. So, I mean, this I don't have to talk about the management of muscle invasive bladder cancer. So there are two treatment options: bladder preservation with a tri-modality approach, TURBT, with followed by concurrent chemoradiotherapy, and the other option you have is radical cystectomy. So these are the 4 myths that I'll be talking to you about. The first myth is that radical cystectomy is superior to bladder preservation. The second myth is perceived contraindications for bladder preservation. And then a little bit about using response to neoadjuvant chemotherapy as a predictor and to select treatment. And the fourth myth is, of course, related to salvage cystectomy. So the first myth, radical cystectomy is superior to bladder preservation. Now, the problem is that the only randomized controlled trial that attempted to resolve this question, the SPARE trial in the United Kingdom, could not meet its recruitment targets. So it closed prematurely because this was a trial which involved 2 specialties. There was the oncologist offering bladder preservation, and there was the urological surgeons offering cystectomy. So this was not a trial that was easy to run. The patient has to move to across 2 specialties. So whomever they met first seemed to convince them that their treatment was better. So it could not recruit at all. The trial closed prematurely, and its results are of no value. But it was an important lesson in conducting trials which span across 2 specialties. So now we are left with retrospective series. So we don't have prospective data, randomized data, so we have to now go back to the next level of evidence, and that is matched cohort retrospective series. And the problem is that patients referred for radiotherapy are older, less fitter, and have more comorbidities. Basically, these are patients who are sort of unfit for cystectomy, and therefore they will have a lower overall survival. And when you go back to retrospective series, the cause of death is not clearly specified, so you can't really figure out what the cause specific survival is. The date of relapse also is uncertain, so disease-free survival is also unreliable. And when you look at some of the large databases in the United States, like SEER and the National Cancer Database, some of the studies that compared radical cystectomy to bladder preservation included patients who were treated with lower doses of radiotherapy, sort of in the lower range where patients were deemed unfit for higher doses. They were also included. So because of that, the doing retrospective cohort is also difficult. But there were some studies that were done. So these are three sort of well-recognized studies comparing cystectomy versus bladder preservation. And you can see here that the RT patients in the Booth cohort was older, and so this resulted in a superior cause-specific survival in favor of cystectomy. However, when this was adjusted for comorbidities and stage and other factors, the significance was lost. The other two studies showed no significant difference between radiotherapy and cystectomy. So this is the survival curve of the study by Kotwal, and again, although there is a sort of a numerical difference, it was not statistically significant. And when you consider disease-specific survival, radiotherapy is superior, but of course, again, even in this cohort study, it was not significant, number one. Number two, this was a retrospective study, so determining the exact time of relapse wasn't very reliable. RT patients were older, as you can see here, and had more advanced disease. So going back to the Booth study, this survival curve shows, so on your left is the unadjusted curve showing that cystectomy is actually superior, but when you factor in comorbidities and do sort of a propensity score analysis, the significance is lost. So actually, based on this, the evidence that we have, it's true that cystectomy predated bladder preservation, so you could argue that that remains the standard of care unless you do a randomized trial to confirm equivalence. So that's one approach, but I don't think we would ever get a trial comparing bladder preservation with cystectomy. It will be very difficult to run. So based on the evidence that we have, certainly you cannot say that radical cystectomy is superior. And certainly the retrospective data that we have shows that both options are equal. So both choices should be given to patients who are fit to receive it, and then depending on the adverse effects of each treatment option, the patient can make an informed decision about them. Now, moving on to contraindications to bladder preservation. So there are numerous prognostic factors that somehow got classified into as contraindications for bladder preservation in patients who are fit enough to undergo a cystectomy. So incomplete TURBT, again a poor prognostic factor. It means the tumor is large and could not be resected completely. Hydronephrosis, again a poor prognostic factor, which has been classified as a contraindication, a relative contraindication for bladder preservation. Large tumors, locally advanced tumors, particularly in Australia and New Zealand, they do not offer bladder preservation if the tumor is T3. So again, something for which there isn't, which is not really evidence-based. Multifocality and again variant histologies also tend to be managed with surgery rather than bladder preservation. Now going back to two trials so the BC 2001 trial was a trial of radiotherapy versus chemoradiotherapy. The Beacon trial was another trial of hypoxia modification with a gas, with carbogen, a gas, against radiotherapy alone. So these were two bladder preservation trials which compared radiotherapy alone with a sensitizer. And these trials, if you look here, had a significant, particularly the Beacon trial had about 22% of patients with stage 3 and 4. And 1/3 of these patients had an incomplete resection. So certainly T3 should not be a contraindication for bladder preservation, because these patients did, in the trials of bladder preservation, they were treated successfully. Hydronephrosis, the BC 2001 trial did not report hydronephrosis rates, but in the Beacon trial only about 1% of patients had hydronephrosis. So that remains a point to consider. And even tumors progressing from non-muscle invasive disease, the numbers were low. So that is another factor you have to consider when you are deciding treatment. But looking at hydronephrosis, if you go back to the phase 2 trial that preceded the BC 2001 trial, they had a significant proportion of patients, nearly half of them had hydronephrosis. The problem was that when they moved to the phase 3 and they were trying to sort of look at the effect of adding a radiosensitizer, they sort of excluded patients with hydronephrosis in the phase 3 trial. But if you go back to the phase 2 trial, you could see half of them had hydronephrosis, and outcomes, local control rates are quite decent. So with modern radiotherapy, we can include the distal ureter, so hydronephrosis should not be a contraindication. What about variant histologies? So anything other than urothelial cancer is traditionally offered cystectomy, but this study in the National Cancer Database shows that there is no difference between bladder preservation and definitive surgery. But going back to the histological subtypes, squamous cell bladder cancer and adenocarcinoma did not do well with bladder preservation, but neuroendocrine tumors and other subtypes performed equally well. So some of the contraindications that we are actually prognostic factors, they do worse whether you do surgery or bladder preservation. So it should not be a factor determining precluding patients from being offered bladder preservation. Now the other myth is that if patients do not respond to neoadjuvant chemotherapy, they should be offered cystectomy instead of bladder preservation. So certainly in the United Kingdom, neoadjuvant chemotherapy is standard of care. So every patient with muscle invasive bladder cancer gets neoadjuvant chemotherapy, and then they have a cystoscopy. If the response is good, they are offered bladder preservation or cystectomy. But if the response is poor, some centers offer radical cystectomy if the patient is fit. But there are problems with this approach. So we know that neoadjuvant chemotherapy has about a 5% gain in survival. Now the trials of neoadjuvant chemotherapy predated chemoradiotherapy. So all of those trials were in patients who received radiotherapy alone. And when you consider chemoradiotherapy, the evidence isn't that robust for the use of neoadjuvant chemotherapy in patients treated with chemoradiotherapy. And the chemotherapy regime, this was a very toxic regime, the MVAC regimen. We no longer use it. It has high neutropenia rates, so we are offering gemcitabine and platinums. Again, so the evidence is sketchy. But when you consider response to neoadjuvant chemotherapy, the problem is that it all depends on the tumor volume and the completeness of your TURBT. If your initial TURBT was complete, these patients, even after neoadjuvant chemotherapy, will still have a good response. So it is not a fair comparison. So using response to neoadjuvant chemotherapy as a sort of a predictor to select patients for bladder preservation or cystectomy isn't a very robust method. And it is certainly a prognostic factor, but not a predictive factor. And if you look at overall survival, you can see that the addition of neoadjuvant chemotherapy did not result in a survival gain in the BC 2001 trial. But in patients not receiving neoadjuvant chemotherapy, there was a survival gain. So, whether neoadjuvant chemotherapy improves survival in patients receiving chemoradiotherapy is uncertain. And this was a study that I was involved in Manchester, and we looked at patients treated with neoadjuvant chemotherapy plus chemoradiotherapy versus chemoradiotherapy alone, and you can see there is no difference. So this was an editorial we wrote to one of the radiation oncology journals, and we said that if you're giving chemoradiotherapy, you should be actually not giving neoadjuvant chemotherapy. If you want, you can consider adjuvant chemotherapy, but not neoadjuvant. So there is no, the benefit of neoadjuvant chemotherapy is uncertain. So response to neoadjuvant chemotherapy should not be used to select patients. You have to decide which modality, what your local treatment is going to be upfront, whether it's cystectomy or bladder preservation. And then if it is cystectomy, of course, you should offer neoadjuvant chemotherapy and then go ahead with cystectomy. But if it is chemoradiotherapy, you should directly proceed to chemoradiotherapy. Now the fourth myth is something that I'm treading upon with some trepidation in front of a surgical cohort. Now, one of the reasons given against bladder preservation is that about 10% of patients treated with bladder preservation will need a salvage cystectomy. And surgeons will say certainly that salvage cystectomy is much harder to do than a upfront primary cystectomy, and therefore that is one of the factors to consider when you're offering bladder preservation. So we may offer salvage cystectomy either due to an invasive recurrence or a superficial, intractable superficial recurrences. Whatever it is, there is a perception that mortality is increased, wound infection is high, and so on. But radiotherapy techniques have improved over the decade. That is something you should factor in. And this was a study again done in Manchester. Of course, this is one of a very sort of a large volume center. Its radiotherapy techniques are also sort of cutting edge. But you can see that the complication rates have dropped. Certainly there is a sort of a still primary cystectomy, the 60-day mortality is still lower than salvage cystectomy. But if you look at 90-day mortality, depending on the decade of surgery, the mortality has dropped. So there is no significant difference whether you do a salvage cystectomy or a primary cystectomy. Complication rates again, so in the same study done by Professor Noel Clark in Manchester, one of the famous urological surgeons, the postoperative complication rates are comparable between salvage cystectomy and primary cystectomy. And the same applies to medical complications. So there is no real reason to dissuade patients from being offered bladder preservation by saying that salvage cystectomy might be more difficult. So modern radiotherapy techniques, we try to focus the beam on the tumor. Now it's true that with the older cobalt machines, we sort of irradiated the whole pelvis. So, I mean, it's fair to say that doing a salvage cystectomy in those patients is going to be very challenging. But with the advent of linear accelerators, we are able to give a more focused, tumor-focused approach. Finally, to wind up, this is data from Sri Lanka. So, this was a study that we did comparing Professor Neville Pereira's cohort and our cohort at Apeksha Hospital. Dr. Munupriya was involved in it and Praveen Taranga. So you can see that there is no difference between cystectomy and bladder preservation. So bladder preservation, in conclusion, is in clinical equipoise with radical cystectomy, and all muscle invasive bladder patients should be seen by a urologist and an oncologist, both, so that an informed decision can be made. Thank you.